Good morning, and thanks for joining me. I am going to mute everybody during the presentation, and then we'll open it up for questions at the end, okay? All righty. So I want to go ahead and get started, be respectful of everyone's time this morning. For many practices, Medicare patients represent a really large portion of your business and your revenue. The MACRA legislation passed last year, and it provides fundamental changes to how physicians will be paid for the services that you provide to Medicare patients. So our goal today is to help you understand these changes and the proposed implementation so that you can go ahead and start making a plan to ensure your success under what's really an entirely new payment methodology for Medicare that begins with payments in 2019 and goes forward by law. Okay, so we have another acronym in our tool chest now, the MACRA, which actually stands for Medicare Access and Chip Reauthorization Act of 2015. It's the name of the legislation. But I have another name for it, which is Medicare Analytics and Convoluted Reimbursement Act of 2015. Cam Cox, who all of you know pretty well, he likes to change that A for a different word, and I won't even tell you what it is. Anyway, the Medicare number of beneficiaries, we all know, is going to be increasing dramatically as the baby boomers age. And as a result of that, the costs for Medicare services also increase to the taxpayer and to the government at a rather astronomical and unsustainable rate by the projections. In fact, the most recent analysis that was done estimated that the Medicare Trust Fund will run out of money in 2028. So before we had MACRA, we had, as many of you know who've been in the business for a long time, something called the Sustainable Growth Rate, or the SGR. And it controlled what the allowable fees for Medicare was every year. It was passed back in 1997 as the way that they would control the costs of Medicare payments to physicians. Essentially, that worked like this. If overall physician costs in a year were greater than what they had targeted to be the Medicare expenditures for that year based on a standard growth rate that was equal to the growth rate of GDP, then the next year physician payments would be cut across the board to bring the budget back in line. That was the plan that was made in 1997, and it worked for a year or two. And then pretty soon the cuts that were required under that methodology became really unpalatable to physicians and their advocacy organizations, and physicians lobbied Congress every single year. So we had these constant band-aids to avert those cuts. In fact, by 2015, the cuts were scheduled to be 21%, which is obviously insane. And for many years, MGMA and AMA and others have been lobbying Congress to come up with a different plan for how this was going to work so that they would not have to go back once, twice, and 3 times a year to avert these cuts. And that's in fact what happened last year. We blew up the SGR formula, changed it entirely. It was agreed on by many people from both parties. It was a really momentous achievement for our advocacy organizations. And what it does, in addition to setting a fee schedule going forward, is it changes us from being paid on a fee for service basis to being paid on a fee for value basis. So I think it's always important to understand what we mean when we say value, because people mean many different things by that. What the government means by value is improving results, by which they mean having better clinical outcomes for the Medicare patients that we see, and reducing the costs, by which they mean controlling the use of resources, controlling the number of tests, controlling the number of visits, controlling the number of admissions to the hospital. And they intend to do that through patient engagement, the use of technology, and process improvement. on the part of the medical practices that will be paid with this. CMS has a stated goal that by 2018, that's only a year and a half away, 80% of Medicare payments will be tied one way or another to value and quality. So that's a pretty ambitious and lofty goal. The timeline for this is the MACRA legislation passed last year in April. It calls for a 0.5% increase, which we all got in July of 2015, and then an additional 0.5% increase each calendar year from 2016 through 2019 by law. Those increases are in the legislation, but it also moves us from paying for volume to paying for value, and that's really what we're going to talk about today. The proposed rule, when Congress passes legislation, they write a lot of big generalizations, and those things are law, and the CMS cannot come through and change what is written into the legislation. But many of the details of how a program like this is going to work is not in the law. It comes out in the regulations that CMS puts out. And CMS is required to publish proposed regulations for the program, which they did April 27th, and they are required to submit those and encourage people to make comments on them for a 60-day period. That period ended 2 or 3 days ago. There are over 3,800 comments that were received by CMS in that 60-day period, including one submitted by MSOC Health. We expect that we will see the final rule November 1st, and the first payment year by law under this new payment approach, it will be 2019, but the first reporting period, the period on which those payments in 2019 will be based, is the 12-month period that starts January 1st of 2017. And you won't be surprised to hear that CMS is giving us very little time to make the transitions that we need to make. Here we are saying we're going to find out November 1st what the final rules are, and we are expected to start implementing them January 1st of 2017 with just a 2-month lead time. And it's one of the reasons that we're holding these MACRA webinars, is because we feel like you're going to have very little time to make the adjustments that you might need to be making, and you really need to be focusing on it now, even though we don't have the final rules yet. So what CMS envisions in their proposed rules is something called the Quality Payment Program, which by law has 2 arms. The 2 arms are the Alternative Payment Model Pathway and the Merit-Based Incentive Payment System Pathway. So every physician in the legislation, every physician and every group is able to choose between which pathway they want to follow. And there are some very significant differences between the two, and we're going to cover both of them this morning. Here's what happens. This is what's in the law. We have the 0.5% increase every year from 2016 to 2019 by law. Then there will be no change in the physician fee schedule for the next 6 years. And after that, starting in 2026, there will be a bifurcated increase in the fee schedule. If you are in the MIPS pathway, you will get the 0.25% increase every year going forward indefinitely, according to the law currently. If you are in the advanced payment model pathway, you will get a 0.75% increase every year going forward indefinitely. Now, if you choose the merit-based incentive payment system, the MIPS pathway, you will have the opportunity to be judged on your performance on value, your performance that we'll be speaking to in great depth today. And in the first year, 2019, you can earn a minus 4% if your performance is deemed lower than average, or an increase in the of up to 4%, or even higher if your performance is deemed outstanding. And those percentages of penalty and increases, potential increases, rise from 4% up to 9%, as you can see in the chart here. In addition, for the first several years, there is an additional 10% of money, there's additional pot of money that has been identified in the legislation, $500 million, in fact, to be distributed among the very top performance providers and groups. On the other hand, in the advanced payment model track, you receive a 5% bonus payment every year. It's a flat 5% of whatever your allowables are. It's paid in a lump sum at the end of the calendar year based on your allowable payments from Medicare in that year. So that's kind of the general layout of what happens. Now let's talk about each of these pathways individually. In the advanced payment model pathway, to be part of that pathway, you have to be deemed a qualifying provider in an advanced alternative payment model. Lots of words there. So let's talk about what an alternative payment model is. Essentially, and this will not be unfamiliar language to you, but on the other hand, a lot of times people throw things out and we're not really sure what we're talking about. So an alternative payment model is something that CMS envisions as being something where providers are at some level of risk for the costs of the services that they're providing. The most well-known alternative payment model is the Accountable Care Organization, and under Medicare it's called Medicare Shared Savings, and I'm just going to talk about it for a minute, how it works at a very high level, just to refresh everybody's mind, and if you don't know, to give you a baseline for our discussions about advanced alternative payment models. So in the Medicare Shared Savings Program, there is an ACO entity. The ACO entity is usually a health system or a hospital and usually associated physicians, but every entity has the opportunity to form itself and to apply and be approved by Medicare to participate in the Medicare Shared Savings Program. They do have to have at least 5,000 Medicare beneficiaries that they see, so these are generally pretty large organizations. Patients, Medicare patients, are actually attributed to the ACO entity. That's done because the ACO served more of the services to those patients than anybody outside the ACO. So think a big health system like a Carolinas Carolinas Medical Center system, or a UNC system, or a Duke system. These are typically your ACO entities, and various patients, even though they may see providers who are not part of that ACO, the bulk of their services are provided by that ACO entity. And so Medicare attributes those patients to that entity. And then Medicare takes the total, they project a total annual costs for those patients based on historical data. And then they're going to take a look at what were the actual costs in, say, 2016 for those patients that were attributed to them. And if they are less than what the projected costs were, and if the organization met quality targets that CMS has as part of this program, then the ACO entity gets a piece of the savings that Medicare made between the actual costs and the projected costs. And then in some models of the Medicare Shared Savings Program, if the actual costs are greater than the projected, then the ACO entity actually has to either pay back money or they have to have a lower than normal reimbursement rate the following year. So in those more advanced models, they have skin in the game. They have actual dollars that they can lose as well as gain by how they perform. And that is, in fact, one of the key components of what CMS is calling advanced alternative payment models. And remember, to follow this pathway, you must be in an advanced alternative payment model, not just a regular alternative payment model. So by law, they have said for 2019 to 2020, and the alternative payment models that will be that are in this pathway must be a CMS program, first of all. It can't be a Blue Cross program or another provider program. It's got to be a Medicare program. They have to require providers to use certified EHRs and to have quality metrics involved and to have financial risk of more than a quote-unquote nominal amount. That's the law. And so then by law in 2021, that will expand to include more than just CMS programs. So CMS in their proposed rule has to identify what does nominal risk mean exactly, and look at their programs and say which of these programs will qualify as an advanced APM. So only the ones in the red circle are CMS programs that one would call an alternative payment model that qualify as an advanced alternative payment model according to the proposed rules. Now, many commenters, including MGMA, are trying to get CMS through their rules to expand that to include all the boxes on this page and not just the ones in the red circle. But obviously we don't know whether that will be the case. Right now in the state of North Carolina, the only entities that would qualify as an advanced APM as it's proposed are Triad Health Network, which is in Greensboro area, and the CHESS Network, which are both next generation ACOs, and the CHESS Network includes Wake Forest Baptist Hospital and area, other providers in that area. So just to let you know that so you have to be part of an advanced ACO, and then you have to be part of you have to be a qualifying provider, meaning you have to be a listed participant, and at least 25% of the providers' Medicare allowables or 25% of their patients have to be one of those patients who have been attributed to that advanced APM entity. Unfortunately, we're not going to know who that is even until the end of the reporting year. Just so that you know, in future years, that percentage is going to go up. Going to go up quite dramatically, and it will also be able to include non-CMS APMs. So essentially, how will people get paid under this pathway? The APM entity signs a contract with CMS based on the program rules for the box that they were in. So the next generation ACOs have a certain way that they're paid, and the Track 2 Medicare Shared Savings Plan have a certain way that they're paid. There's rules for each of those programs. The entity gets paid based on those rules to start with. Then at the end of the year, the providers who are qualifying providers in that organization will receive a one-time lump sum payment of 5% of the allowable fees for the Medicare patients, for all Medicare patients that they saw last year, and it's paid after the end of the payment year. And as I mentioned before, those people in this pathway are going to eventually have a higher allowable rate than other providers. A very key point to this side is that all providers really, even if you are in one of those organizations that are in the red circles, and even if CMS extends that to other types of CMS programs, you still need to plan to participate in MIPS for the first year, because we won't know who is a qualifying provider until the end of the year. So if you have not gone ahead and planned to participate in MIPS and done the things that are going to make you successful under the merit-based incentive structure, and then you get to the end of the thinking that you're going to be part of the APM side of the equation, and then you get to the end of the year and you find out you are not because you didn't reach the 25% threshold, for example, then you will not be in good shape. Okay, so I'm going to go forward now and talk about MIPS. I think this does definitely apply to all providers, even those that are in APM organizations. And essentially what CMS has done here is they have combined the meaningful use, PQRS, and value-based modifier programs into a single program and made some fairly substantial changes in them along the way. We're really changing the payment model. How will you get paid? Right now, Right now, when you get paid, you file a claim, and each service is identified by a CPT code. The CPT code has a fee schedule that has an amount of money attached to that CPT code for a given year. CMS pays in general 80% of that allowable fee, and then they pass the claim either to the patient's supplemental insurance plan, or the patient pays the other 20% at the time of service, hopefully, or via a patient statement. So how will that change under this model? Essentially, same process. You're going to file a claim. You're going to put a CPT code on it. There is a set fee for that CPT code based on the 0.5% increases every year. But then every provider will have a payment adjustment factor that is applied to that allowable fee. And CMS is going to pay 80% of that adjusted amount. It could be higher or it could be lower. And all of whether it's higher or lower than the standard allowable fee is what we're going to be calculating through this MIPS program, a single performance score that puts a provider higher or lower. And then, of course, CMS passes the claim on to the supplemental plan, and the patient pays the other portion. So we're replacing meaningful use, PQRS, and value-based modifier. All of those programs stop as of the end of this year's reporting period, which, of course, as you know, impacts your payments in 2018. We are really moving to pay for performance, right? So for the reporting year of 2017, again, it will impact your payments 2 years in the future. This is very familiar to you, this lag time. The maximum reduction is -4%. It is actually possible for that increase to be as high as 12%, and so on. And you see how it increases over the years. Now, if you add up right now the potential penalties from meaningful use, PQRS, and value-based modifiers for the payment year of 2018 based on this year reporting, it's like 7%, 7 to 9%, depending on the size of your practice. So it's actually, if you think about this, we're actually going back down. You know, we have a 9% risk now, up to 9% risk now, and we're going to go down with next year's program to a 4% risk of negative, but that's going to grow over time. So also focus on the increase side. This year, for people who were participating in the value-based modifier back in 2014, some of those people got a 32% increase in their Medicare payments because they were outstanding on cost and quality. So you have the opportunity not just to avoid losses, but also to actually have increases here if done right. The reason the increases can be so much more than the plus 4% is because the program's budget neutral. And what that means is that CMS is going to take all the money that they save by the people that get penalties, that get reductions, and they're going to distribute that money among the practices who have increases. So if there are if there are many practices with reductions, and or if those reductions, or if those practices have pretty big reductions, then there's more money to distribute among a smaller pool of practices that have increases. So you can actually get quite a bit. And there's that additional $500 million a year for the first several years that will go to just the top performers by law. So who is an eligible clinician in this program? Because you'll remember that PQRS, meaningful use, value-based modifier all kind of have different definitions of who's eligible. The people who are now eligible for MIPS, starting in 2017, are physicians, physician assistants, nurse practitioners, clinical nurse specialists, and CRNAs. So if you have dietitians, if you have occupational therapists or physical therapists or clinical psychologists or social workers in your practice, they are not eligible for the MIPS program at this point in time, and that's by law. It can be expanded to include them after 2019 reporting year. So you've got a little bit of time to get started, and those providers will be paid just the standard allowable rate. There are a couple of exceptions. A provider who does a low volume of Medicare patients is excluded from the program and would be paid the standard allowable amount. CMS proposes to define low volume as less than $10,000 in Medicare allowables for the year and less than 100 Medicare patients for the year. So a few providers may be excluded for that. If it is the provider's first year in billing to Medicare, having a Medicare number at all, so not just in your TIN, but in any tax ID number, any practice, they're excluded. And if you're a qualifying provider in an advanced APM, you're excluded. You can report data to CMS either as a group, if you have more than two or more providers in your group, or as individual clinicians. All of the payment adjustments, however, will happen at a tax ID/NPI level. So if a provider works in two different practices, they could have one payment rate in one practice and one payment rate in the other practice, for example. So every provider will get, at the end of this process, a composite performance score, or CPS, that I have here. The composite performance score for each provider will range from 0 to 100. And CMS will choose a threshold every year. We don't know what CMS's threshold will be in 2017 reporting year. They said they will tell us in November with the final rule, and they do say it will be based on historical data. But we don't know what it is. But just to use an example, let's assume for a minute that it's going to be 60. Every single point between 15 and 100 will be given a particular adjustment factor. So even though I've got 5-point ranges shown here as an example, it's not every 5 points, it's every single point. Every single point results in either being paid more or less. So if your score is 65, you're going to be paid 0.5% more than the standard allowable rate. If your score is 95, you're going to be paid 3.5% higher, and everything in between. And the same going down until you get to 25% of the threshold. After that, everybody gets 4% penalty. So what makes up that composite performance score? Obviously, this is the key issue here. We're going to score from 0 to 100, and by law, the law says there will be 4 things considered: quality, resource use, performance improvement, and advancing care information. And the law assigns weights to each of those categories, which change over the first 3 years and then stay constant. So you can see those here. We're going to talk about each of these categories in some depth. So let's start with the quality category. The quality category is very much like PQRS. Quality reporting. There will be 300 or more measures. They look pretty much exactly like the 281 plus measures in PQRS for 2016. But there are no domains like we have seen in the past. Instead, there are some subsets. There are subsets of measures that are identified as outcome measures, high priority measures, and cross-cutting measures. So some of those 300 measures are in each of those subsets. And there are 27 specialty sets defined. So there is a specialty set for dermatology services. There's a specialty set for orthopedics. There's a specialty set for electrocardiology, I think. So there's 27 different specialty sets defined. Those are, again, subsets of all the measures. You don't have to use the specialty set, but that's either suggested or you can use them if you want to. You will be required under the proposed rule to report on 6 measures. Any 6 measures that you choose, except one of the 6 has to be a cross-cutting measure, and one of the 6 has to be an outcome measure. If you don't have any applicable outcome measures, then one of the 6 has to be a high priority measure. CMS is definitely trying to move all of this to measures that are about outcomes instead of measures that are about process. Right now, most of our measures are about process. Did you communicate with the referring physician? Did you make a medication list? whatever. Outcome measures are measures that are much more about outcomes. Most common measure on the inpatient side that's an outcome measure is a readmission to the hospital or a death. That's an outcome. So they are really trying to focus us on the outcome measures here. And CMS is proposing to require that you report for these measures that you choose on 90% of the patients that would be eligible for these measures. That's 90% of all patients, not 50% of Medicare patients, as we currently know for the PQRS program. Given that number, and this concerns me about knowing the final rules in November and starting January 1st, the issue here is that if you're supposed to report on 90% of eligible patients for the year 2017, you've got to be ready to start collecting and that data really January 1st, January 15th at the latest to get to 90% of all eligible patients. It's got to be part of your process. It can't just be something you're doing in addition or an extra thing. It's got to be built in to get to that level. So your quality category, you will report the data via registry or via qualified clinical data repository. I keep needing to change that. It's kind of backwards. Or by your EHR. These are all ways that you can report PQRS measures today, and they remain pretty much the same. You can also report via claims, as you can PQRS today. Much like PQRS, you cannot report as a group via claims. You must report only as individual clinicians, and they did say if you report on claims, you will be expected to report 80% of eligible Medicare patients. Of course, how would they know if you were reporting, it has to be on Medicare patients because those are the only claims that they get. That's all they know. There are no measure groups, which is a popular way that some groups have been reporting quality measures, especially smaller groups where you could just look at a sample of 20 diabetics or 20 patients with COPD and report on a set of measures for those 20 patients. That is not included in the proposed rule. Our comment and many others have asked that it be reinstated. I don't know whether it will succeed or not. CMS will then add to the 6 measures that you have submitted to them, they will add 2 to 3 what they call population-based measures. And these are measures that are largely around inpatient services. They're the same outcome measures that were added in to the value-based modifier program on the quality side from CMS. They did say that the all-cause hospital readmission rate would not be calculated for practices that have less than 10 providers. So that's why some will have 2 added and some will have 3 added to the 6 that they report. So how do these things get scored? This is quite different than what we have seen in the past. They are going to take each measure and they are going to lay out the performance scores for each measure. What percent of your patients did you do the quality activity on? That's the performance score. They're going to lay out the scores they get from every provider who reports that measure or group, if you report as a group. And they're going to array those going from the highest to the lowest, or the lowest to the highest, and then they're going to divide them into 10. So that if you had 100 providers who reported, as an example, the 10 providers with the highest scores will get 10 points. And that score on one measure could range from 62 to 100%. On another measure, maybe the top 10% of reporters for this might have a score of 90 to 100%. So on every measure, there's going to be a different level. And basically what your score is based on is what decile your score falls in when they're arranged from high to low. So as an example, if you were a provider with this layout for this particular measure, and they say they're going to tell us all this November 1st, what all the deciles are for all of the measures. If you had a score of 50%, it's exactly halfway between 42 and 58. So we would find where we are on the right hand, of the table, right-hand column, and say, okay, I'm in the 8th decile, because I'm between 42 and 58. And then where in that decile am I? In fact, 50% happens to be exactly halfway. So you would be assigned 8.5, but some providers could be assigned 8.1, 8.2, 8.3, or any of the numbers in between. So each measure is going to be scored, and then we're going to add the scores up for all the measures that you report plus the measures that CMS adds in, and we'll add up all of those, and the most you could get for any measure is 10 points. That's the highest. So then we're going to create a single quality score that is the ratio of those two numbers. So our example is our total scores were 51. We had 9 possible measures, 10 points each. So our score is 56.7 for the quality category. Now notice measure 6 says not reported. If you don't report 6 measures, it's not like PQRS where, oh, you're done. You didn't report 6 measures. That's too bad. You're out of there. You're going to get the penalty. No, you just don't get any points for that measure. So that is what, in fact, significantly reduced our score here, from being much closer to 90. If we had a 9 or a 10 on that, we would automatically be significantly higher. So you can report not the full number of 6 measures, and you will just have a different score. So resource use, moving on, so that's how the quality category works. The resource use score works really the same way, and it uses 2 of the 3 measures that are currently used for value-based modifiers on the cost side. It still attributes patients, just like value-based modifiers does, to your practice based on which provider had the largest number of E&M outpatient codes. And it measures their total cost, which is the per capita cost, and then around a hospital episode of care. So if you don't do inpatient services, you probably won't have anything in that particular measure, or you'll have a very small number. At any rate, the measures are done by CMS's looking at your claims data. So you don't report anything for this. CMS uses the claims data to do it. One thing they have done is they've added in, they have 40 different episodes that they are proposing. For example, a knee replacement episode is a knee replacement surgery is done, and the episode is X number of days before the surgery to X number of days after the surgery. So if you are a provider that provided the knee replacement surgery, a patient would be attributed to you if the cost of that time period was greater for you than any other provider, and you would be held responsible for those costs in this measurement series. And again, you're going to have an average cost across all of your knee replacement patients that are assigned to you or attributed to you. You're going to have an average cost, and they're going to lay that average cost against everybody else in the country, decide what decile you're in, decide which score you get in that decile, and then add up your scores and divide by the maximum number that you could have. As an example here, where I have episode 2 cost, this is a case where a provider had less than 20 patients that were, attributed to them for that episode of services. And if there are less than 20 attributed to a provider, then that is not scored because it's too small to be statistically valid. So if it's not scored, you both get a 0 for the score, but you also get a 0 in the maximum number. That's different than the example I gave a minute ago where the quality score was 0 because it wasn't reported. It was there, but it just wasn't big enough. So that's how resource use works. It's pretty similar to the quality piece. So let's move on to meaningful use, which becomes something called advancing care information. Advancing care information, they just like that term better than meaningful use, which if you just hear meaningful use and you're not in the healthcare industry, you have no idea what this means. What it means to them is it means use of technology for improving healthcare. And so they have renamed it. And just to review, in the current meaningful use structure for 2016, you have to use a 2014 certified EHR. You have a 12-month reporting period from January through December of 2016. There are actually 8 measures where you have to say yes. You're required to answer yes to 5 clinical decision support rules, to doing a security risk assessment. All these sound familiar to you. I'm sorry, there are 8 measures that have a required threshold or percentage to pass, and there are 6 measures that are yes or no or require just one patient, like the secure messaging measure requires you just to have one patient. And the whole program is all or nothing. If you don't pass all of those measures by meeting or exceeding the threshold, or by answering yes, or by having one patient, if you don't pass all of them, then you automatically get the full 3% cut. You know this. Under the current meaningful use program in 2018, we are moving to stage 3 measures. They're required in the reporting year 2018 to use new measures that are part of stage 3, and you're required to have a 2015 certified EHR. So how does advancing care information change this program? We will now, under MIPS, as proposed, have a base score and a performance score, and those 2 scores will be added together. The base score will be all or nothing. You will get either 0 points or 50 points for the base score. It's made up of 9 measures, and for those 9 measures, you have to say either yes, or you have to have a numerator that is greater than 0. In other words, you have to be able to say, yes, I did that for one patient. So any numerator, as long as it's greater than 0, is fine. And those 9 measures, if you do all of them at either yes or a numerator greater than 0, you're going to get 50 points of the 100 possible points in this category. Now, on the performance score side, there are 5 measures, and they are 5 of the measures from the modified stage 2 rules that we're using this year in 2016, same as last year. And for these, at every score that you make is going to be converted to points. So whatever your score on the measure is, if you score 100% on the measure, you're going to get 10 points for that measure. If you score 10% on the measure, you're going to get 1 point. And if you score 50%, you're going to get 5 points, and every number in between. So there is no more a threshold you have to pass. You just get more or less points depending on what your score is. And then, of course, in 2018, as we move to stage 3, there will be additional measures added into this performance category that come from the stage 3 rules. So that concept of moving to stage 3 in 2018 reporting year is not different. The concept of needing a 2015 certified EHR is not different. You'll need that for 2018. What does happen at that point is there will be actually 8 measures worth 10 points each. So everybody can add. That makes 130 total points possible, 50 on the base score and 80 on the performance score, which is obviously bigger than 130. If you get more than 100 points, they're simply going to give you 100 points is what they're saying. So this is what it might look like. This is an example of practices likely scores in 2017. So I'm using the modified stage 2 rules, and I'm using the way it's going to work for the first payment year. Certain things, all the items on here, in fact, are included in the base score as either a yes, no, or at least one patient. And this particular practice gets all of their base score items. They did a security risk assessment. They're able to attest yes. They have e-prescribing, and they have a numerator more than 1. You know, each of these items need to have a numerator more than 1 or a yes-no answer, or in the case of the immunization registry, if you're excluded from the immunization registry because you don't do immunizations, you get an okay. And then, so this practice gets 50 points from that base score, from having all of those things be yes or greater than 1. Then on the performance score, only 5 of the measures count for the performance score. So the fact that you do a lot of e-prescribing and medication reconciliation, they don't care anymore how much you do, just that you do it. But they do care, they will make points out of these. And you see the 2 there that are currently required to be just 1 patient. If in fact you do just 1 patient, you will have a score of 0, or I guess maybe it would be 0.00001, but I assume they're not going to take it out further than 1, decimal place. So you basically get a 0 score for it because you didn't have, on the other hand, if you had 1,000 patients who viewed, downloaded, and transmitted their data, you would get a score of 10 for that measure. So we add up all of our performance scores. In this case, I've got 16. And my score for this category is the sum of the bonus score and, the base score and the performance score is 66 points. So obviously there were a few providers who were not previously in meaningful use. They weren't required to do meaningful use, so good question, what happens to them? The providers that have not had to do meaningful use in the past are those who are hospital-based, had more than 90% of their Medicare patients in hospitals, inpatients, and emergency rooms. If they were non-patient-facing providers like anesthesiologists, pathologists, radiologists, if they were PAs or NPs or CRNAs, or if they had a hardship exemption. These were ways that you got excluded from the meaningful use program under the current program. So in this program, the proposal is that for all of these people, the PAs and nurse practitioners and CRNAs only in the first year, but for all of these people, they would get an advancing care information score of 0. But the weight that was assigned, this category back on our weighting had a 25% weight. That weight is to go and be reassigned to the quality category. So essentially for these types of providers, the quality category would be worth 75% and they would not have any advancing care information or meaningful use category. That's how they propose it to work. The last category we're going to talk about is called CPIA, another acronym for Clinical Performance Improvement Activity. It's the performance improvement category, clearly. CMS has given us in the proposed rules 90 activities, and they want you to attest to doing at least 6 of those activities, well, at least 60 points worth of those activities in your attestation at the end of the year. So you can pick from the 90 activities what you're doing. Most of them have 10 points assigned to them for each activity. Some of them are considered high weights and they have 20 points. So you can mix and match and get as many points as you want to get, but you can't get more than 60. And what they're saying in the proposed rule is you have to perform that activity consistently during any 90-day period of the reporting year, and you report this via attestation. So here's a couple of examples of activities that they give us, just because people don't have a clue what we're talking about. And like I said, there are 90 of these. I see this category as really being sort of a gimme. I don't think it's going to be very hard for any practice to find 60 points worth of activities listed there that they either are doing or that they could easily implement doing in order to get through this section. There are a couple of special circumstances for this category. First of all, if you're a patient-centered medical home recognized by NCQA or these other organizations, or a patient-centered specialty practice recognized by NCQA, you automatically get full credit for this section, which is worth 15% of your total score. If you're a practice with less than 15 providers, you don't have to get 60. You can just report on any 2 activities and you will get the full credit of the 15%. Similar if you're in a rural area or a HIPSA, or if you're a non-patient facing provider, like an anesthesiologist or pathologist. You also get 50% credit on this category if you are a participating provider in any advanced payment model, including the Medicare Shared Savings Program Track 2, Track 1, or the other ones on that initial screen, so not just advanced ones. So now we're going to put all our pieces together. In each category, we've got a score. We've got a maximum that's possible for that score, for that category. We've got a percent of the maximum. That's a calculation. 51 divided by 90 is 56.7. And then each category has a weight identified by the legislature as what the weight will be for this year. And exceptions, like I was saying, certain providers may have 0% weight in the advancing care information and 75% weight in quality. And then you calculate that for a final score. So this particular example, we have a final score of 65.1 points. And again, we're going to put that on this scale from 0 to 100 of all providers laid out, 0 to 100, and CMS is going to tell us a threshold. This example suggests it might be 60. They did use 60 as an example in the proposed rule, but they were very clear it was an example. So I don't know what the threshold will be, but if it was 60 and our provider had a score of 67.98, they would be earning the standard allowable plus 0.8% on every claim that they submit to CMS in the payment year. So there's this exceptional performance bonus, which is made up of a bonus pool of $500 million every year divided among the tax ID number NPI combinations, the providers that have the highest composite performance score. They're proposing that they're going to give that money out to any provider that is in the top 75% of providers above the threshold. So if we looked at this one, for example, that if 60 was the threshold, the 25th percentile is 70, and everybody who gets more than 70 is going to get some additional incentive money on top of whatever they're getting because of their performance score. And CMS is proposing that that will range from 0% to 10% total. So what that means is, while it's very, very, very unlikely, it is possible to earn as much as 22% more than the standard allowable in 2019. If you had a composite performance score of like 100 or very close to 100, and you might be right at the top, and if CMS had enough money from the money they save to redistribute the full amount. Once again, just to review the proposed rule, we have the proposed rule. The 60-day comment period ended earlier this week. We are thinking we should have, they have said they will have the final rule by November, although they do have to respond to 3,800 comments between now and then. We, of course, have an election coming up, but this whole MACRA legislation had very strong bipartisan support. It has been years in the making in terms of advocacy from MGMA and AMA, not that they don't have comments and things that they don't like about the proposed rule, but they were all very involved in creating the legislation. So I don't see the elections making things just radically turn around. Our reporting year, as currently proposed, would start in January of 2017. Now, you won't be surprised to hear that MSOC Health, as well as AMA and MGMA, and probably a lot of other comments, have suggested that that's unreasonable and that we should only have the first year reporting year be 90 consecutive days, or some maybe said 6 months or something. But so it's possible that they will go back on that and it won't start January 2017, but we won't know that till November, which doesn't give us any time. Data submission will happen as it is doing now with meaningful use in PQRS for most people from January through March of 2018 based on the whole calendar year of 2017. And then we'll see the feedback reports from that in the fall of 2018, and we will start to see our payments adjusted in January of 2019. So deep breath, that's a lot to absorb for sure. And we will distribute these slides out to you as well so that you can review this again at your leisure. But let's talk a minute about some strategic options for practices. What do I do with this now that I know this, what's in this proposed rule? Well, your first option is to do nothing. It's not a totally unreasonable option for some people. Let's say you had $100,000 of Medicare revenue. As I mentioned, for many practices, the most that you can lose this year, based on what you do this year, for that $100,000 is either $7,000 or $9,000, depending on the size of your practice. Next year, the most you can lose is, or for the 2017 reporting year, the most you can lose is $4,000. So if you haven't been doing meaningful use in PQRS and you are getting those penalties, you'll actually no foul to continue not to do it. However, you will continue to get those penalties. They will be smaller, but they will grow. So if you don't do it, you have some impact. Option two, and I think some practices really should consider this, is to become non-participating with Medicare. It's not at all uncommon for primary care providers to be non-participating with Medicare. And the way that program works, you have to tell CMS you're going to be non-participating. There's a deadline for doing that before the first of the year. And basically what happens then is you are allowed to set your fee. You're basically going to get a fee that is 9% approximately above the standard Medicare rate. The patient pays you that entire amount at the time of the service. And then the patient, you can file a claim to CMS still, and then the patient will receive the reimbursement instead of you. So the patient pays you 9% approximately above the Medicare rate. At the time they get the service, they get a reimbursement, and they're getting about 70% of what they paid back. So obviously this it clears you from having to do all this quality and meaningful use stuff, and it makes the patient have to pay more money. Because currently they would be paying only 20%. In this scheme, they're going to be paying 30%. The pay practice does have the option to accept assignment on specific patients if they're non-participating, meaning they can say, for this patient, I'm going to not charge them, and they don't have to pay. I'm going to file a claim and you pay me, and for this patient, I am. Obviously, that's some effort and work and confusion. But in the end, if you do that, when you file the claim for the patient and accept assignment, your fee is 5% less than the Medicare rate. So this is not for everybody, but it is something that is worth considering. We have asked CMS to clarify what exactly the patient will be responsible for paying once there's a penalty. If there's a MIPS penalty, what do they pay? And if you get a MIPS increase, what do they pay if you're non-participating? It's kind of a little confusing. So we'll see what that comes out with. But it is an option to think about for some practices. And your third option is really to be one of the few. It's what I told you at the beginning. Some practices this year are getting a 32% increase. It's not a lot, but some are. Now CMS in their proposed rule has to estimate what the impact of their proposed rule will be on the marketplace, on the healthcare marketplace. And this is their table with their increase and decrease. CMS expects, based on their calculations and historical data, that 87% of solo practitioners in the first year will lose money on this and will lose an average of $3,356, and that only 13% of solo practitioners will be on the plus side, and they will gain $7,894 on average. This is per provider, is my understanding. And again, you see the different sizes of the practices. Clearly, CMS, and I think everybody looking at this program agrees with this, is envisioning that it is the larger practices that will have the resources, the manpower, the specialized expertise to be successful in the first year, especially in this program. And because it's budget neutral, all the dollars for under the MIPS program, all the dollars that are saved will be distributed to the people who gain. And so if the numbers that gain are relatively small compared to the numbers that lose, then the gains can be quite large. So to be one of the few, what you really have to do is embrace change. I think really the whole meaningful use and PQRS and value-based modifier program for most practices has been seen as an add-on thing, something that they had to do to avoid penalties, but they all started out as sort of bonus payments, and so they were always viewed as add-ons. It's really time to change that and to view this as something that has got to be part of the structure of what you do, and not just something that's an add-on that we're going to do to avoid getting a penalty. It really has to become part of the way you operate. And what that takes is really to focus on the value to the patient that you are providing. How do you, for your patient, provide better clinical outcomes? How do you control resource use for your patient? CMS suggests that you would do that through patient engagement, the use of technology, and through process improvement in your practice. So it doesn't mean the add-on things that we've been doing with meaningful use. How do I click the button so it counts? It really means figuring out what you can do to bring more value to your patient. If Mrs. Jones wouldn't have to come in and see you every 3 months, if only she would do something, what do you do to remind Mrs. Jones that she needs to do something at home? What do you do so she doesn't have to come in and see you? Because you're not paid on only a fee for service anymore. If Mrs. Jones gets better at lower cost, you have an incentive under this program, a financial incentive. You're going to help be in the top section and get more money from Medicare for helping Mrs. Jones not use your services. Or how can we communicate with the patient's caregiver so that they have the information that they need? Because right now we're relying on the 80-year-old woman who comes in to remember what we told her she needed to do at home to go get her medication. How can we get that information, not to Mrs. Jones, but to whomever helps Mrs. Jones, whether it's a home health worker or whether it's their son or their daughter or their cousin or their niece that lives close by? How do we make sure that Mrs. Jones and whoever helps take care of her gets the information and is engaged in doing the things that we're recommending that they do so that they actually have better outcomes and have lower costs? That's what CMS is hoping that the entire marketplace will start doing. So to aim to succeed in 2017, to be one of the few, it is going to take your providers understanding this and being committed to it. I know that's really hard, and the people I have on the phone today are more administrative, and but you've got to get the providers on board. The providers have to walk the talk. It's not just the staff following along behind the providers, taking care of all the little things. It's got to be a change in mindset at the providers, and they have to be the ones that are marketing that to the staff, helping the staff understand why it's important, because they're the leaders in your organization in general. Or no matter how much you might lead as an administrator, if they undermine you, that does not work. You're going to need to monitor results throughout the year and publish them and help people know where they are and where they're trying to get to. And I strongly encourage that staff needs to be rewarded and incentivized. If you are actually going to make more money on Medicare patients because you are doing all these things differently, then the staff needs to be involved in understanding what that benefit was and in getting some of that benefit themselves in their own pockets to help them to understand and to change. What you need to do now, first, learning all you can. You've clearly taken the first step here in learning about the MACRA proposed rules. Obviously, if you're not participating in PQRS and meaningful use in 2016, you need to be doing that because it's the fundamental baseline for what's going to continue going forward. If you have not gotten your QRUR report and reviewed it, the 2014 full year report is available. There is a mid-year 2015 report available, which really only gives you the cost data. And that we will see our 2015 full year QRURs in about September. And then obviously you want to go ahead at this point and make a preliminary plan. See whether you are or are not in an advanced APM. Compare the quality measures that you're currently doing for PQRS to those that are on the proposed list. Make sure you know, do you have an outcome measure in there? Do you have a cross-cutting measure in there? Do you have a high priority measure in there? So that you could continue to use the same measures that you're using now and really work toward the strongest possible performance rate on those measures. Particularly, maybe you're working for 9 measures right now, and if the proposal is not going to go up, it's not going to become 9 measures instead of 6. It might get fewer, but maybe targeting which 6 you're really going to try to focus on going forward and trying to really have super strong performance for those, at least, if you can't do all of them. You can go through and basically estimate your scores for each category based on your data that you have for this much of 2016 so far. What would it look like if we scored it this way? And begin to get a sense of what might be your potential impact on your Medicare revenue. We're your partner in this. We're providing, through this webinar and other mechanisms, free education for all of our billing clients. And we are also offering, as we have done with PQRS in prior years, a MIPS consulting package, which is deeply discounted for our billing clients. And what we envision here is really walking you through this whole process, helping you, providing whatever education you might want us to provide to your providers and staff, helping you understand your QRUR reports, making a plan, then tweaking it when we have the final rules that come out, monitoring your results with you every quarter, helping you with attestation and submission, giving you reminders of the program deadlines, and of course all of your, any questions that you have answered. So it's really, it's a 1.5 years, really long process, maybe even almost 2 years. But we think that is what people need to be focusing on doing. I've included some resources for you, and at this point I'm going to go ahead and unmute everybody so that I can take questions if I have not totally overwhelmed you all. Hold on while I get that button. Okay. So everybody is unmuted. If you do have a question, just go ahead and ask me.
Jeannie, I have a question.
Yes.
Michelle, sorry. I got a bit confused where it was, we can report this still as a group, correct? Or are we supposed, or do we have to report each provider individually now?
No, you are able to report as a group under the proposed rules. The proposed rules, however, do say that if you report as a group for one category, you must report as a group for all categories. So okay. You can't report what we're doing quality now. Measures as a group and meaningful use as individual providers. In the past, okay, now, the current rule, right, you have to report meaningful use as individual providers, and you can choose on the PQRS side. But under MIPS, you're going to need to pick one or the other. You will not have to register by June 30th anymore to do it. You just do it, unless you're going to do something called GPRO website reporting, which you won't be doing. So, yes, so you can still report as a group.
Okay, we just have to choose if we're going to do it individually or as a group. We can't do both.
That's right, and you have to do all the categories the same way.
Okay.
Mm-hmm. Any other questions? No? Well then, yay, I ended early. Thank you so much. And I will send out the slides to you all. And I look forward to working with all of you on, whatever questions you have. If you have questions after the session, please feel free to give me a call as you think this through, and I look forward to working with you. Thanks.
Hey, Jeannie, do you know when you'll send out those slides? Because I have stuff that I've in my brain I want to document on there.
How about if I send it right now?
Great. Thank you so much.
Okay, take care. Bye, guys.
All right. Bye-bye.
Thank you.